Free audio post-production by alphonic.com.
Find out if when this person is given a diagnosis, do they want to be in the driver's seat? Do they want to be in the passenger seat, navigating but not driving necessarily? Or do they want to be in the back seat, like literally hand it off to someone they trust and love to digest all of the information and help them navigate? But they really don't want to know much detail. They're just like, just tell me what to do and where to show up and I'll do that. I'm Dr. Tina Kaczor, and as Leah likes to say, I'm the sciencey one.
And I'm Dr. Leah Sherman, and I'm the Cancer Insider.
And we're two naturopathic doctors who practice integrative cancer care.
But we're not your doctors.
This is for education, entertainment, and informational purposes only.
Do not apply any of this information without first speaking to your doctor.
The views and opinions expressed on this podcast by the hosts and their guests are solely their own.
Welcome to the Cancer Pod.
I'm here today with Dr. Chad Levitt. Dr. Levitt is a board-certified radiation oncologist with over 25 years of experience in cancer treatment. He studied existential philosophy and creative writing as an undergraduate before attending Emory University for medical school and residency training. Dr. Levitt is recognized nationally for his experience in cancer care, with numerous speaking engagements and published research in oncology journals. Dr. Levitt has also served on national advisory boards and as a principal investigator for clinical research trials, staying at the forefront of cancer treatment innovations. After decades of practicing oncology, Dr. Levitt realized the existing gaps in the current systems and the need for a truly patient-centered approach to cancer care. To address the often fragmented care between multiple providers, incentivized by multiple interests, Dr. Levitt founded ONCARE MD to put the patients back at the center of their cancer care. Having already made a difference in countless lives, his passion is to provide you and your family with the personalized and dedicated professional guidance you deserve. Dr. Levitt, thank you so much for joining me.
Thank you. Happy to be here.
When we were chatting a little bit before the official video and audio got recorded, you were sharing with me your current passion and kind of going off the bio that I just read. Tell me a little bit more about how to put the patient at the center of the process of their oncology treatment. I guess that is much of what our audience is searching for. So how do we even begin?
Right. Basically, ONCARE MD and my current interest on this topic specifically, from what most of us oncologists do routinely anyways, once or twice a month, we get a call from a friend or family member talking about somebody who's encountered a new cancer diagnosis. And we often help them throughout the whole process, help them design the right questions to ask, how to speak the language about the diagnosis and all the medical terms, how to prioritize the stresses and the anxieties and the fear and all the emotions that come along with the cancer diagnosis. Not to mention how to make sure all your doctors are speaking to one another and speaking the same language in a consistent way with you at the center. It makes a huge difference. And so it's not easy, but the biggest take-home message is that where healthcare, most of the modern Western healthcare has evolved to today, it's created a landscape that's not too different than any other corporate or institutional entity. And if you think about it that way, as a patient, wanting to get the best care and be involved and engaged in your treatment choices about what type of treatment you might want to do or how to integrate different therapies. It really requires thinking about yourself as needing to be an informed consumer of healthcare, not any really different than how you would go about buying a car or a TV or a pair of shoes. In those situations, you speak the language, you at least are somewhat familiar with the process and the options. But cancer and disease, they're hopefully once in a lifetime type of experiences, and most people aren't taught or familiar with how to interact or deal with it. They need somebody who's not necessarily incentivized by ordering this test or this treatment or guiding them towards this or that, especially with cancer, where we haven't cured all the disease.
Mm-hmm.
And so we don't have, nor should we pretend to have all of the right answers for every situation. So it is a team effort, and it should be, and a patient should feel entitled to consider themselves as really the captain of the ship. They just might not have gone to maritime school to learn how to sail the ship. And that's our job as healthcare professionals to guide patients where they want to go, inform them about what their options are, the pros, the cons, the risks, the benefits, and then help them to get there as long as it's reasonable and safe and responsible. So informed consent is critical, but that's often the glossed over portion of what a patient's interactions with the healthcare team it consists of.
Yeah, I think what you're bridging in my mind as I listen to you is you're bridging the gap between what is ideal, like what you're describing is an ideal scenario for every patient every time going through treatment, having to choose the treatment, choose their medical care team, choose how they're going to go about after they get the diagnosis, how they're going to go about treatment. Idealistically, yes, they're in the center and they've got a lot of people around them who are experts in whatever field they are. But I would say that is a minority of
Yeah.
patients.
Yeah, that doesn't really exist in the standard common experience. And so the biggest thing that patients and people helping patients through a diagnosis like this is not to be shy about asking questions and asking for what you'd like. You can kick the tires on a lot of teams and doctors because the relationship is critical. And other than in a few more unique circumstances, cancer treatments are often not an emergency. Now, if they are, you got to get taken care of so you can thrive and heal and then consider longer term options. But paying attention to, do you feel like the provider, the doctor, the team that you're working with is listening to you, is answering your questions in a way that you understand, is explaining things to you to help you make decisions that are informed. You shouldn't be afraid to ask questions if you don't understand something. We know that once someone tells somebody that they have a cancer diagnosis, they only hear maybe half of what we say after that. I
Right.
mean, it is the kind of trauma and the PTSD that comes with just hearing the word cancer is real. We
Yeah.
know it happens. And so that's never a time you want to make the huge decisions. And so I guess the first thing is I would tell most people is put the brakes on for a minute. Make sure you have a support team that can be an extra set of ears for you. Take notes. Kick the tires on the doctors and people that you're working with. Does it feel like they have a foot out the door before they've even finished the visit? And that's just a reality. It's not realistic
Hmm.
today to think that a routine oncologist has the time to do a great and extensive detail-oriented workup during the diagnostic portion to make sure that all the great new science and advances that are out there that help us better personalize and direct treatment and integrate care for patients are looked at and thought about. And
Hmm.
that's sort of the first phase in my mind. The second phase is a really detailed and comprehensive informed consent in a language and in a way that the patient and their team and their family can understand. And you weigh for them. There's option A, B, and C. Here are the pros and cons of each. Let's get to know you and what's important to you to help you make a decision. And then also, thirdly, be excellent at delivering that treatment. Is it surgery or chemotherapy or radiation or nutritional analysis or mind body medicine or energy work, any of these things? Um, so to be great at all those things isn't realistic anymore. So
Right.
it's up to the patients to consider themselves as part of the team, if not the captain of the team, and want to understand all of these details so that they can make an informed decision and not look back no matter what the
Hmm.
future holds and wish they either had done more or less or done more research. So
Yeah.
that leads to the idea of second opinions are a good thing.
Yeah, and we've often talked about here at the Cancer Pod about how finding loved ones who are really good at advocacy can also help because sometimes it's just exhausting, the treatment itself, the processing, the decision making, the gravity of the situation sometimes. You just need other people. And so it's really, I mean, that's sometimes a hurdle for folks, right? Like to ask others to help them go with them to the visit. Or maybe, the best person isn't your partner or your spouse. Maybe the best person is your best friend or your sister, or your brother, and making sure that that person becomes the closest advocate when it comes to digesting a lot of information, really,
Yep.
and organizing it in a way.
Yeah. The spouse often isn't the best person to deal with all that. Now, when people find out that you're dealing with a cancer diagnosis, whether it's an early stage, very curable one or something more advanced, it seems like people come out of the woodwork wanting to help you.
Mm-hmm.
And this gets into some philosophical, psychological things where how do you help somebody when you don't know what it is that they need? And there's a selfish aspect to wanting to say, look, my friend or I went to this person and did this and this and this, and you really need to look at this. What most of us don't realize is that a patient may be getting that from 20 different sources,
Right.
and it's from people who care about them. And there's this weird sort of guilt that can sometimes occur, which is normal. And it's often healthy to hear that this is a normal experience because more people dealing with a cancer diagnosis experience something like this than not, that they feel guilty that they can't look at every single thing that everybody's telling them to go do. And it stresses them out. They have to become an expert on how to look at this treatment or this clinic or this doctor or this procedure. So one of the aspects of having an advocate that's a loved one, a friend, or someone like that is sort of to set up protective layer for that patient
Mm-hmm.
to help manage all the people who want to help and support them, but protect them from feeling that's yet another duty that they as a patient have to do. A lot of my messaging is how can we offload the majority of the logistic and information type of stressors that come with the diagnosis that you're trying to navigate so that a patient and their family member can really just focus on the healing and the supportive care and the minimization of side effects and looking towards the future, whether it's living with cancer or without cancer in spite of it. um, that's a lot of the logistics. The reality is probably one of the worst things about a cancer diagnosis is it's just a slap in the face about our human condition and how frail life is anyways. And you could wake up every morning thinking about that just by putting on the TV or reading, classic novels or anything. But you're not going to get up out of bed and go be productive if you're constantly thinking about how short and frail and precious life is. Like you can't live just in the moment. But a cancer diagnosis sort of forces you to think about those aspects of life
Mm-hmm.
more than you ever had in the past, and it makes it exponentially amplifies the seeming importance of every decision. And so
Mm-hmm.
how do you prioritize those is also something that we all need help with.
Yeah.
So information, some people are calmed by more information, some people are overwhelmed by it. So there's a real personalization that comes to it that is important for patients to express to the doctors and team that they're working with. This
Yeah.
is how I'm wired. This is what works for me. If you're telling me there's a 3% chance of this treatment benefiting me, but there's a 12 or 25% chance of me having insomnia, isn't it up to me as a patient to decide if I want to include that aspect of the care?
Right.
But that's just not the routine conversation. It's
Yeah.
more, this is the best way to treat you, and it removes the individual a little bit.
Yeah, generally people are told what they might be given a choice between A and B, but not like all the pros and cons of A and all the pros and cons of B. When you were mentioning knowing whether you're one of those people who wants all the information, and I went to a lecture years ago. I wish I remember who gave it to give them credit for this, but it always stuck in my mind. They talked about as a clinician, and I'm sure this is true for just in general, it's a good kind of thing to run through your head. Find out if when this person is given a diagnosis, do they want to be in the driver's seat? Do they want to be in the passenger seat navigating but not driving necessarily? Or do they want to be in the back seat, like hand it off, literally hand it off to someone they trust and love to digest all of the information and help them navigate? But they really don't want to know much detail. They're just like, just tell me what to do and where to show up and I'll do that. And defining who that person is so important. And I've always used this with loved ones as well as patients. There is one of those three seats that people want to be in, and they're very clear about it if you listen closely.
Yeah.
Yeah, and some of those people who are just like, just don't give me any details, they want to be in the back seat. And honestly, all of them work. There's no right way or wrong way. It's just whoever you are as a person is who you bring into that diagnosis and into the room when you're a patient.
And you got to remember that we don't, they don't really teach you in medical school how to be a good communicator or an empath. You either come to the table with those skills or you learn them or you don't. Historically, many doctors come from a science background and they're really good at absorbing huge amounts of information and regurgitating it and assimilating it. But no, we don't get a lot of hands-on training. It's changed as the
Yeah.
generations have changed, but different diagnoses come with the patterns related to what you're talking about. Gender identity is much different today, but historically, a prostate cancer is diagnosed by a urologist.
Mhm.
And historically, most urologists are male. The urologist is the first line of recommendations as far as what the treatments are also. So I diagnosed you. Now I'm going to talk to you about the treatment options. Oh, and by the way, I also do a lot of those treatments. Um, there's books written about this, but the traditional male psychology is, all right, you're telling me I've got a problem. I'm going to grin and bear it and just take care of it. What do I got to do to fix it? And
Mhm.
tell me, and I'm gonna get it done. And they jump to reflexive decisions that when it comes to prostate cancer, it's a huge dilemma because there are a lot of different treatment
Yeah.
options for prostate cancer, all of which have the same exact cure rate but are very different. You could do
Mhm.
a big surgery on someone. You can use radiation. Some situations you can use medicines. It's a mind-bending array of options,
Mhm.
and it's very easy with a few select words from a person giving you the information to say, look, here's a problem. I've got a good fix. I happen to have some time in the OR next week. We can take it out. It'll be over and done with, and let's get it done with. Most guys sign up for that if they weren't more well informed.
Mhm.
And it's not infrequent that some of those men end up in diapers without being able to hold their urine, losing their erectile functions or other issues. Most are fine, but the ones who aren't often look back and say, gosh, I didn't even know there were other options. I wish I had taken my time. It wasn't an emergency. As a society, we're all recognizing this more now than we ever did in the past, but not all prostate cancer needs to be treated
Right.
and nor even diagnosed. And so when you look at statistics like the diagnoses are going up or they're going down, it's, are we making the diagnosis? Are we doing the blood tests? Are men living longer because of treatment or just because they've been diagnosed earlier and they didn't have one that even needed to be treated?
Yeah.
Not
Yeah.
dissimilar in the female world. The difference with most historically traditional females is that from a very young age, they're used to going to the doctor. They have a close annual relationship.
Mhm.
There's a comfort level in, this is not a big deal. I don't need to be scared. This is like not something I have to rush to. And they can often have a much more informed conversation with their doctor because they just are coming at it from a place where there's a better comfort. Still, for many years, we were doing mastectomies unnecessarily, probably a good decade to 15 years more than we needed to after the data, but
Mhm.
adoption and treatment de-escalation takes a long time to penetrate into the culture.
Yeah. Yeah. That whole idea of laying out all of the possibilities and then explaining to the patient why you are choosing the one that you think is best for that person would be the ideal scenario. As you mentioned, that doesn't happen often, and most oncologists don't have the time for it. I did notice that the NCCN guidelines, which for our listeners is the NCCN guidelines are what your oncologists are actually using to look at various updates on the standard of care for the given treatment. There is a patient version of that I would
Mhm.
encourage anyone who's listening to at least look at that because that will lay out options and you can see what you're not getting as you go through, and it's also good for side effects and stuff. But I think to myself, because when they switch from mastectomy to lumpectomy plus radiation, for example, I mean, I've been doing this 25 years, so,
You've seen
yeah,
it.
so I've been here long enough to see the wave switch over and, total lymph node removal versus partial lymph nodes, all of that. Interestingly, I'm a naturopath, so there's a certain selective certain
Yeah.
select patients want to see a naturopath in the first place. Well, let's just say that it's not the average person off the street. So some of them um, didn't realize, they had it in their head that they were going to refuse radiation because they had a left-sided cancer. They don't want radiation on their left side. They don't want it near their heart. And I would every single time say, you need to talk to your surgeon about this. You need to know whether that's a good idea or not, because the first data that came out, right, was mastectomy equals lumpectomy plus radiation as far as outcomes. It didn't say so these women were like, I was like, no, you're refusing part of the treatment that way. You need to know that is like, should you get a mastectomy? If you don't want radiation, if you are philosophically opposed to radiation on your body and that's what you want to do, that is your prerogative, but you need to know that a mastectomy may be more appropriate for you then to get the same results you would have otherwise gotten. So it goes back to your point of like being fully informed and looking at the information.
Yeah. And semantics matter, unfortunately. When it comes specifically when it comes to radiation, that's scary sounding stuff. Most people don't know what we're talking about. I had to get a master's in nuclear physics to understand
Mm-hmm.
the quantum level even of, is it, we're past it in a little bit now, but is it a photon? Is it a particle? Is it a wave? And you hear about radiation, you think Chernobyl, Hiroshima, and horrible things. And it's really probably one of the most effective and safe options for certain patients today. And in breast cancer, we're getting even away from that now, which is great, with just lumpectomies and no radiation for some patients. Knowing what the studies show are the benefits is appropriate, but it's also important to understand what the modern options of these treatments are when it comes to safety
Mm-hmm.
and how important and safe some of these things are. Because, it used to be go from a breast cancer, you get a lumpectomy, it was like 6 weeks of x-ray treatments every day, still relatively safe. But today, many women could go for 5 treatments, 1 a day, 30 minutes a day, 5 times, and you drop the recurrence rate in most patients by 50%. I mean, when we're talking about chemotherapies and drugs, we're talking about 5 and not even 10% benefits in survival and cure rates in a lot of patients. So when you have something like that's a slam dunk and also very safe, for instance, the example you brought up, compared to a mastectomy, which is a big surgery with a lot of healing and a lot of potential risks, compared to something that honestly can be over and done with in a couple of weeks, you do have to be informed. But how do you know how to ask those questions?
Right.
It's so NCCN, since you brought that up, is a great resource. I have some. I have a not a unique, but my point of view on guidelines
Mm-hmm.
is kind of my point of view on statistics. We need them, but the patients aren't statistics, and guidelines are the lowest common denominator, which is what standard of care really is.
Mm-hmm.
Standard of care is what should you be able to get if you go to most places around the country? What's available? What's appropriate? What do we know? But when it comes to personalized medicine and individualized care, the guidelines are really the most common foundation of where you should be starting, not the end of the conversation. And it's up to us as healthcare professionals to inform patients and also to inform patients about what it is we do know, as well as what it is we don't know. So that's where this integrative oncology, integrative medicine field or idea is just critical. And it's not new. It's just finally being much more appropriately talked about and embraced. I get a lot of patients now after they've seen their first oncologist, because they'll go to an oncologist and say, okay, well, here's the regimen. We're going to do surgery. We're going to do chemotherapy. And then the patient says, okay, doc, well, what kind of food, what kind of diet should I be eating? And the doctor's like, oh, just don't lose a lot of weight. Eat whatever you want. And someone who's in tune with there's more than just the hospital-based medicine it knows that probably isn't the case.
Yeah.
And we all kind of know that.
You know, what's interesting is that's actually eating away at the trust with that oncologist at that point. When the oncologist says something so old school, you kind of now you're like doubting their intelligence and their ability to give you the best treatment possible.
Exactly. And exactly, which is such a critical part
Mhm.
of getting through all this with your best possible outcome
Mhm.
for you as an individual. So there's a generational thing happening in Western medicine. I had a junior partner that had trained, and in many of our meetings and many of our tumor boards, and even to patients, he kept quoting the guidelines. And I
Mhm.
was like, we're not AI that can go read the guidelines and spit them out. We're here to talk about what we know and where we think things are going for this individual patient. And we had a lot of referring doctors who said, I wish he'd just stop quoting the guidelines. We all know the guidelines.
Right.
We're here to practice and to help. Cancer is a Sisyphean endeavor, meaning like the myth of pushing a boulder up the hill that you can't ever quite get to the top. Oncologists are a rare breed in that we're comfortable without knowing all the right answers, but we were that kind of student who really thrived in studying and knowing everything. So you
Yeah.
have to be wired in a way that you can be aware of what you don't know and then reach out to people who do
Mhm.
on nutrition, on energy work, on mind body medicine, on spirituality and faith, or whatever it is that
Mhm.
might round out integrative care.
Yeah, it takes being present. I don't care what degree or what letters come after someone's name when they're a
Right.
clinician or practitioner of any kind. If they're present and they're listening, they can often be very helpful and part of a healing team. I think that I think what unfortunately the time crunch has created in a lot of clinics is the inability to be present. You're thinking about where you just came from, you're thinking about where you need to be, but you're not present. I hear that as a complaint from patients. But I also just feel like some of this is just such logic and human nature, and I think people would be better clinicians if they had enough time.
Absolutely.
I think the time crunch is it's not that they're a bad person, it's not that their heart's not in the right place, it's not that they chose the wrong profession. It's just that the system has basically wrung every piece of juice out of them, so they've got to see 25 patients a day, and in order to do that, you got to
That's
average
light.
15 minutes. That's a light day?
That's a light day for a lot of oncologists.
Yeah, which is a crazy concept. That's not care, that's being a technician. So,
Yeah, it's a provider.
yeah.
So I had a conversation with one of my great, brilliant oncologic colleagues, when I was starting OnCare MD, and I always believed that it was true for the most part, that if you put the patient at the center of all your decisions and work and energy, and you focus on what's best to help them, everything else will fall into place. The business, the research, our understanding, your fulfillment. And I'm like, so really we work for our patients. So a few years ago when I founded OnCare MD, we were having this conversation. He goes, I used to think that too. He goes, the reality is we work for systems, and on behalf of these systems, we take care of patients.
Mm,
And you're not allowed to really say that out loud if you
right,
don't want to get called in into the HR department or something, med staff office sometimes. But anyway, so OnCare MD for me was freeing and fulfilling because I stepped away from treating the patients,
mhm,
because with taking insurance, with worrying about referral patterns, with being employed by a corporate environment, there's a lot of strings attached to what kind of exposure and liability you have. And if you really do want to be present and spend time with patients the way you'd want to be cared for, it stinks. You sort of have to step outside of the current landscape.
mhm.
And it's disruptive to the spreadsheets and the corporate overflow of coding and billing and reimbursement and all of the stuff that everyone hears about, big pharma and insurance and hospital settings and Medicare and these programs. I think they're all looking to serve a needed purpose,
Mhm.
but we've reached a place, society has reached a place of scale that is probably not what most of us would have intended. It's nobody's fault, but we're talking about how do individuals navigate things on their own terms. And if you have to think about it that way, then you want to realize the landscape we're living in. And it is a large industrial, corporate, technologically fast and money driven landscape. And those are the wheels that make things work. So to be an individual, you do need to advocate for yourself or
Right.
find people to help you do that and
Right.
balance all of these things.
It's an interesting line because you have to acknowledge that reality and yet not become a cynic.
Yes.
And that's a fine line, right? Before you just reject the entire system and say, "I'm not doing any of it." And I think that's to people's detriment too. So there to hold to hold that space for the reality that exists and yet navigate the current system in such a way that you get the best care possible, it's challenging because you do have to acknowledge all of that and the machinery of the money-making machine that is oncology today, and somehow use bits and pieces of it for the best treatment while you deny other pieces of it. And I kind of think of your service now that I'm hearing kind of what you do and understanding it better. You know, in a lot of centers that are more progressive, at least, they have patient navigators. And a patient navigator is like a smidgen of what you do because they are usually somebody who's either a layperson or an RN maybe who helps the patient understand what's going on in that particular facility. You know, that's Dr. So and so, and then the patient has one contact, and it smooths out
Well,
the
you got to look at
communication.
who employs those navigators too.
Right. I was gonna say it's not a perfect system.
The navigators mean well, but they're
It's
given a menu of services to provide. And that menu usually doesn't include their competing hospitals and
right.
competing doctors'
Yes.
practices. It usually is oriented to, we've got everything you need right here.
Yes.
And so navigation, advocacy, the semantics have already been established in a way that's different than how I'm using them.
Right.
Uh, so our value propositions are that we're experienced oncologists with decades of practice in these landscapes, and we have no incentives other than, I mean, we're a membership model.
Mhm.
We don't take insurance, and so we had to do that to remove all this bias and allow us to really focus
Mhm.
in a timely way. I started this right out of COVID. I was going to do house calls and sit down with patients in their room and their family home with their supportive team and dive into this without a time limit in the comfort of their own home and in a way that we could learn about each other and what makes them tick. Um, but nobody really wanted that. After COVID, everybody wanted telemedicine, which I think
Oh,
is
sure.
great and it works great. But I spend more time with patients now than I ever was able to when I was the treating physician in the clinic.
Yeah.
I miss some of those technical aspects, but reality is treatment today is the easiest part. It's easy to figure out what dose of this drug or that radiation to give somebody and to point the machine in the right place. It's easy to go do most of the surgeries that are routine and common and then hand the patient's recovery and care and adjuvant treatment on to someone else. The hard part is the intangibles that we're talking about.
Yeah.
And it really all comes down to what you were mentioning too about this being present and mindful.
And it seems to always return back to just listening and understanding the patient for who they are as a person. I have a distinct memory of a lovely patient I had who had metastatic ovarian cancer. And strangely enough, when she was in my waiting room, her gynecologist came through who happened to have his own cancer. And he turned to her and he knew who she was and said something about fighting the good fight or something like that. And she stopped him and corrected him right on the spot, which I thought was like very brave of her because most people don't talk back to their doctors, and especially of her age group. She was older. And she said, "I don't think of it as a battle. I don't use those terms." And she just was just like basically, that's yours. That's not me. And it was really like I took inspiration from that. And I also listened very closely because I never use those words myself. If a patient does, that's fine. But I try to avoid them myself because I don't think of it that way either.
It, it's a chapter in life. Disease, chronic disease exists. Living with cancer and dying of something else. And today we're at a place where there are many treatments out there that you take a pill for,
Yeah.
and maintenance therapy. Even in stage 4 breast cancer, you can have an expectation of living a decade or more right from diagnosis today. And that was never heard of in the early 90s or mid 90s. Life is
Yeah.
precious and you can't constantly be in the moment wallowing in how amazing it is. you have to have the ups and the downs. You have to have the cycle of experiencing time the way we do to look back and reflect and to be prepared for the future, but hope for the best. Yeah,
Yeah.
a lot comes with with the cancer diagnosis. So a patient really should feel empowered to put value or priority on whichever aspects of these types of things that we're talking about that come with a cancer diagnosis
Yeah.
that are important to them,
Yeah.
you know? And some patients are going to say, look, I get it. You wouldn't do what I'm going to do, but this is my journey. I appreciate you educating me, and I'm making a decision that's right for me. And
Exactly. Mhm.
honestly, that's what most of us should hope for. And
Yes.
um, we're getting there. I think there's a change in the overall consciousness of doctors recognizing they don't know everything, and but it's really like I think before we started recording, we were talking about to care for someone, to truly care for someone, you have to be self-aware and you have to be humble and check your ego at the door as much as we're able
Yes.
to learn and listen to the person you're there for.
Exactly. Exactly. And hopefully, my hope is that through discussions like this and through the podcast and through other kind of more integrative oncology that an awareness out there, people have more self-agency and they do realize that the doctor is always working for them. They might get their
Yeah.
paycheck from the hospital, but ultimately they're working for you when you're the patient and you have the authority to make a change if you don't like it and if
Yeah.
it's causing you any stress or
Yeah,
you.
that initial process, I mean, sometimes the best thing that can happen is the doctor shows you some ugly true colors that they just are burnt out, they're exhausted, they don't have a lot of patience. They might be good at treating you, but they're not going to be your warm fuzzy partner along the way. You'd rather know that earlier in the journey than not.
Mhm.
And it gives you an opportunity to find a better fit.
Yep.
But I think the biggest message is there's no one size fits all. Integrative medicine is probably the best thing that's ever happened in the conversation piece. We've got such amazing cutting edge science happening right now, diagnostics and therapy and harnessing the power of the immune system. These are expensive, resource heavy studies and treatments from a, let's say, a hospital or a clinic delivery system. But on the other side of the coin, what I think is also super cutting edge is this conversation about our understanding of the importance of nutrition and the inflammatory state of the body and the cortisol levels and stress. And that's just in the language that we can talk about. So you've got amazing things happening on both sides of traditions of care that
Mhm.
want to work together, and the providers do.
Mhm.
But it is a really crowded space. There's a lot of semantics. As of just in this talk, we've used the terms differently. You do have to be careful, but
Mhm.
really the only way to do that is to be inquisitive and in a
Yeah.
way that works for you.
Yeah.
And don't just be okay with your eyes glossed over when someone's telling you a whole bunch of things with terms you don't understand. Take a
Right.
breath and ask them, what do they mean by that? And if they don't have the time right now to explain it to you, could they point you in a direction of some resources that could help you better understand it so you can work together as the team?
Absolutely. Absolutely. So if people wanted to find your services as
Mhm.
far as helping them navigate the whole system and find the best possible treatment out there,
Yeah.
how would they find you?
I'm medically licensed in most states around the country. OnCareMD.com is our website. I'm the founder and chief medical officer. We keep a limited number of patients in our practice so that everybody really feels like they're the only one and we have plenty of time. We are not just a second opinion point of view. It's a membership we found because I could point people in the right direction, but really the execution of
Mm.
your treatment plan and strategy is where a lot of miscommunications, mistakes, and all those kinds of things happen. So we have an annual membership. We also have a short-term engagement for things that just need to get pointed in the right direction. There's so many different aspects. We really customize to the patient and their team what they are looking for. Before every doctor's visit, before every treatment, before every test, we touch base. We help them bullet point their questions these are the things we're trying to answer. Here's our contingency plans. If this scan shows this or this, we've got a plan for each. We debrief with them after each of those visits. So it's really a lot of touch points to make sure that everybody's on the same page and working together. Ultimately, the oncologist, because a lot of people say, well, what is my oncologist going to think about another oncologist? We're not looking over their shoulders in a critical way. We're like liaisons to the treatment team.
Mm-hmm.
And the doctors, most of the time, they end up appreciating us more than they ever knew, because our patients and the people we're working with come more informed to make the most efficient use of the limited time and resources and energy that the doctors or the healthcare professionals have, so they can get down and dirty, and they don't have to have yet another conversation about, well, an IV is a tube that goes in your arm and we put it in with a needle. Okay, we get all that. We get what chemotherapy is. We get what immunotherapy is. Let's talk about this type versus that type. And then the doctors are like invigorated and they say, gosh, this is great. We're all, because they're there for the right reasons. It's definitely a hate the game, not the players landscape. And that's unfortunate for us all. And I'm worried about things when I get older, like another 10 years. I hope things are at least as good as they are now, if not better.
Yeah. Yeah. Well, thank you so much. I know you're a very busy person, so I really appreciate you carving out some time and talking to me today. And I hope folks can follow up and check your services out. We will put a link, of course, in our episode notes, and you will have a guest page on our website as well, so people can check you out there. So thanks again for being here.
Yeah, thanks for having these kind of conversations. I think it's definitely in the right space.
Yeah. Yeah. Here's to better care every day for folks.
Appreciate that.
Thanks for listening to the Cancer Pod. Remember to subscribe, review, and rate us wherever you get your podcasts. Follow us on social media for updates. And as always, this is not medical advice. These are our opinions. Talk to your doctor before changing anything related to your treatment plan. The Cancer Pod is hosted by me, Dr. Leah Sherman, and by Dr. Tina Kaczor. Music is by Kevin MacLeod. See you next time.
Free audio post-production by alphonic.com.